Hello everyone, I am myself Dr. 𝗑𝐲𝐫𝐞. I am the general medicine educator. So in this particular section, I'll be discussing the hepatology topics, out of which the first topic that I'll be discussing is about the alcoholic hepatitis. So if you take this spectrum of the alcoholic hepatitis, how does it first initially start and how it will progress and how it will finally end up in. So initially, upon the excessive alcohol consumption, the individual will develop fatty liver. And at the stage of fatty liver, the disorder, it is reversible. Once the individual stops taking alcohol, that fatty liver will get reversed. From the stage of fatty liver, it will progress to a state of the alcoholic hepatitis. Right? From the stage of the fatty liver, it will progress to alcoholic hepatitis. And if the individual continues to consume the alcohol, then the alcoholic hepatitis will progress to the development of the alcoholic cirrhosis. Now, the point is, like, what percentage of the patients with cirrhosis, they will have the mortality. So almost 50% of patients who progress to cirrhosis, they have 60% 4-year mortality, right? And what are the causes of death in patients who are consuming the alcohol? So if the individual is having a binge alcohol consumption, the individual may land up in the atrial fibrillation, and that would be the cause for sudden cardiac death. So binge alcohol consumption can cause sudden cardiac death secondary to the atrial fibrillation. Now, upon alcohol consumption, what are the pathological changes that appear within the liver? So first and foremost, there will be ballooning of the hepatocytes, okay, and that ballooning of the hepatocytes is mainly because of the changes due to fatty liver. And next important is there will be macrovesicular fat deposition in case of the alcoholic fatty liver or alcoholic hepatitis. So what do you understand by the word the macrovesicular fatty liver? So this is the hepatocyte, right? And in this hepatocyte, you have the accumulation of the fat. Okay, so the entire cell is completely filled up with fat. And the nucleus, it is at the periphery. So nucleus is pushed to the periphery. That is what is called macrovesicular fat deposition, right? And this alcoholic hepatitis, right, it will initiate, it's an acute hepatitis. So there will be infiltration of the neutrophils, right? There will be infiltration of the neutrophils, and these neutrophils will release the inflammatory mediators, and they are the one which will cause the spotty necrosis, and this spotty necrosis will activate the stellate cells, right? And in these patients with the alcoholic hepatitis, there are presence of the inclusion bodies. And what are the inclusion bodies? These inclusion bodies, they include Mallory-Denk bodies, right? They are called Mallory-Denk bodies, right? And these are the one which are not seen at low magnification. Now, apart from alcoholic hepatitis, there are many other clinical conditions where you can have the presence of the Mallory-Denk bodies as the inclusion bodies. What are those? That includes first and foremost, it is the alcoholic hepatitis. Then one more important condition is obesity, where the individual will develop what is called NASH, that is non-alcoholic steatohepatitis. So in non-alcoholic steatohepatitis, even though the individual is not consuming alcohol, there will be development of macrovesicular fatty liver, and this is secondary to obesity. And next important condition is due to increased copper overload, and that we consider it as the Indian childhood cirrhosis. Next is Wilson's disease. This is also a disease mainly due to the ceruloplasmin deficiency, and which will cause accumulation of the copper in the liver and multiple other organs, and primary biliary cirrhosis. So these are the other conditions where you have the presence of the Mallory-Denk bodies. Now, the individual who is consuming alcohol, he goes into a state of alcoholic hepatitis. But what are the risk factors for an individual with an alcohol consumption to go into a state of alcoholic hepatitis? Along with the alcohol consumption, if the individual is also having a superadded HCV infection, genetics, obesity, and non-alcoholic fatty liver disease. So these are, right, so these are the risk factors for the development of the alcoholic hepatitis. What will be the clinical features? See, in early stages of alcoholic hepatitis, the individual is asymptomatic. But as there is enlargement of the liver, as the liver span increases, the individual will have a right upper quadrant discomfort. The individual will have a right upper quadrant discomfort, okay? And why is there discomfort? It is because of hepatitis, that is due to inflammation. So there will be right upper quadrant discomfort. and followed by that these individuals will have nausea, vomiting, jaundice, and that is due to impairment of the bilirubin metabolism, and there will be tender hepatomegaly. So there is enlargement of the liver, right? So that is the one which will make the individual to develop what is called a tender hepat. And why it is tender? Because there is a capsule called 𝐒𝐮𝐻𝐬𝐫𝐞 capsule that will get stretched, and once the capsule is being stretched, which is pain sensitive, that is the reason why the individual is said to be having a tender hepatomegaly. Now as the severity progresses, that is from where the individual moves from alcoholic hepatitis to alcoholic cirrhosis, that is the point when the individual will develop the palmar erythema, right? Spider nevi, which will be there mainly over the shoulder areas and as well as the upper thorax. Dupuytren's contracture, that is mainly due to fibrosis of the deep fascia of the palm. And there will also be development of the portal hypertension, right? So this particular portal hypertension is the one which will occur once the individual from alcoholic hepatitis has progressed to alcoholic cirrhosis, right? And so they will have the signs of the portal hypertension. What will be the signs of portal hypertension? There will be development of ascites, there will be development of the caput medusae, there can be development of the esophageal varices, which ruptures can make the individual to develop hematemesis, and there can be also the hemorrhoids as well. So these are all the features of the portal hypertension. And how will you diagnose this? So you need to do an ultrasound abdomen, which will show you that there is enlargement of the liver span, and because of the increase in the portal venous pressure, right, due to increase in the pressure within the portal vein, there will be portal vein reversal. That means the blood actually from the portal vein has to enter into the hepatocytes. From the hepatocytes, it has to enter into the hepatic vein. But because of the cirrhosis of liver, there will be reversal of the flow within the portal vein. Okay, so portal vein reversal will be there. And actually, how can you confirm the diagnosis? Is the confirmation of the diagnosis is done by the biopsy, right? But what is the non-invasive investigation which can confirm the diagnosis? That is by transient elastography. So transient elastography will show you the presence of the fibrosis, whereas the liver biopsy will show you the structural changes that will be happening within the liver. And what will happen to the PT and as well as the INR? So when you do a liver function test, the PT INR are being elevated, right? The PT INR will be elevated. So why the PT INR being elevated? Because the coagulation factors are also synthesized within the liver, and once the liver is damaged, the PT INR are deranged. Now the next important is the enzymes. So if you take the enzymes in case of the alcoholic hepatitis, see, you have SGOT and as well as SGPT, right? So if you take the ratio of SGOT to SGPT, the ratio is like more than 1. Ratio is more than 1. And that is due to mitochondrial injury which is caused by the alcohol. Whereas you take in case of viral hepatitis is exactly, it is reverse. That is SGPT to that of the SGOT ratio will be more than 1 in case of the viral hepatitis, right? So in case of the viral hepatitis, so this will be the picture, right? And what is the marker that to tell that the individual had a heavy alcohol consumption? The marker for heavy alcohol consumption is the gamma GGT, right? Please remember that. Then how will you assess the severity of the alcoholic hepatitis? The assessment of the severity of the alcoholic hepatitis is being done by the MELD score, Glasgow score, then MADRS discriminant function score. What is important for you in the exam is they will ask you what are the components of this MELD score, that is model for end stage liver disease. That includes the bilirubin, INR, and as well as the serum creatinine. So these are the parameters, right? So you can just remember it as bilirubin, INR, and then the creatinine. And if the MELD score is like more than 21, then you need to start the treatment. That is one score. Next is Glasgow score. So Glasgow score, if you see, the parameters which are there included in the Glasgow score will be age of the individual, WBC count, blood urea nitrogen, bilirubin, prothrombin time. So these are the parameters within the Glasgow score. And if the Glasgow score is like more than or equal to 9, if the Glasgow score is more than or equal to 9, then we consider that the patient is said to be having a very severe form of alcoholic hepatitis, and the individual is said to have very high mortality, and in these patients the corticosteroids are being recommended, right? In these patients the corticosteroids are being recommended. Okay, so that is about the Glasgow score, right? And next is the MADRS discriminant function score. So this is the one which is used to assess the severity of the alcoholic hepatitis. So what are the parameters in this Madrid's discriminant function score? The parameters in the Madrid's discriminant function score will be like prothrombin time, then serum bilirubin. So these are the components, prothrombin time and as well as the serum bilirubin. And if the Madrid's discriminant function score is like more than or equal to 32, then this particular patient have to be started on aggressive treatment. And that particular aggressive treatment will be steroids. Right, this particular aggressive treatment will be steroids. Okay, so steroids, they are the mainstay of treatment to reduce the inflammatory component, but you need to decide when to start the steroids. That is like MELD score should be more than 21, or Glasgow score should be more than or equal to 9, and Madrid's discriminant function score should be more than or equal to 32. Then at the same time, you need to be aware of what are the drugs that has to be given for withdrawal of the alcohol, right? So that is alcohol de-addiction. So we have two important molecules, that is naltrexone and as well as the acamprosate. These are the two drugs which are given for the alcohol de-addiction. Okay, and drug of choice is what? That is prednisolone. And what is the dose at which the prednisolone you need to give is 32 milligrams per day, and you have to give for at least 4 weeks. Right, you have to give for at least 4 weeks. And the alternative is the pentoxifylline. The alternative is pentoxifylline. Okay, now you take these two drugs, that is naltrexone and as well as acamprosate. They are given for alcohol de-addiction. And what is their mechanism of action? If you take naltrexone, see, the alcohol will produce the pleasurable effects by acting on the opioid receptors, right? But whenever you give this naltrexone, what the naltrexone will do? Naltrexone blocks the opioid receptors to reduce the alcohol pleasurable effects. Right, the naltrexone, it blocks the opioid receptors to reduce the alcohol's pleasurable effect. That is about the naltrexone. Next important is acamprosate. So if you take this acamprosate, it modulates the glutamate and as well as gamma aminobutyric acid to restore the neurotransmitter balance. Right, to restore the neurotransmitter balance. So that is about the naltrexone and as well as the acamprosate. So naltrexone, it blocks the opioid receptors to reduce the alcohol's pleasurable effect. Then acamprosate, it modulates the glutamate and GABA to restore the neurotransmitter balance. Okay, so this is about the alcoholic hepatitis. So mainly you need to be aware that the spectrum, fatty liver, alcoholic hepatitis and as well as the alcoholic cirrhosis. Pathological changes will be like ballooning of the hepatocytes. And you have the inclusion bodies, that is Mallory-Denk bodies, and the risk factors are mainly the HCV, genetics and as well as obesity. Clinical features, they'll have the tender hepatomegaly, and in advanced stages you will have all the features of cirrhosis. Diagnostic tests include the ultrasound abdomen, PT-INR will be raised, and the liver biopsy is the one which will confirm the diagnosis, and the other one is fibroelastography. Then the markers, if you observe, SGOT and as well as SGPT, right? So if you take SGOT to SGPT ratio, it will be more than 1. And what is the marker of the heavy alcohol consumption? That is gamma GGT. And the scores which will assess the severity is like MELD score, Glasgow score, then Madrid's discriminant function score. And in the management, like the alcohol de-addiction, that is naltrexone or acamprosate are the two drugs, and drug of choice will be prednisolone. The alternative will be pentoxifylline, right? Now, so the next topic for the quick revision will be cirrhosis and as well as its complications. You take cirrhosis. Always remember, cirrhosis in early stages, it will be reversible. Right, it will be reversible. Now, what are the leading causes for the development of cirrhosis? So cirrhosis, again, depending upon the underlying etiology, we have micronodular cirrhosis, right? We have micronodular cirrhosis, and then we have macronodular cirrhosis. Micronodular cirrhosis mean where the size of the nodule is less than 3 mm. Macronodular cirrhosis mean where the size of the nodule is more than 3 mm. That is macronodular cirrhosis. Now, what is the most common cause for macronodular cirrhosis? That will be viral hepatitis. Most common cause for macronodular cirrhosis will be viral hepatitis. Whereas the most common cause for micronodular cirrhosis will be the alcoholic liver disease, right? Then what are the other conditions which will cause the cirrhosis? That includes hemochromatosis, where there is excessive accumulation of the iron within the liver, and this hemochromatosis will cause micronodular cirrhosis. Whereas one more infiltrative disorder, that is Wilson's, right? So in Wilson's, you will have macronodular cirrhosis, right? In Wilson's, you will have macronodular cirrhosis. And the other important etiologies will be alpha-1 antitrypsin deficiency will also cause the cirrhosis of liver. Then coming to pathological changes. So cirrhosis, where you have accumulation of the fibrous tissue within the liver parenchyma, right? So you have bridging fibrous septa, and this bridging fibrous septa will be bridging the nodules, right? Will be bridging the parenchyma's nodules. And finally, there will be disruption of the liver architecture, right? What is that we have discussed in alcoholic hepatitis stage? In alcoholic hepatitis stage, there will be infiltration of the neutrophils, there will be necrosis, activation of stellate cells, there will be Mallory-Denk bodies. But here in cirrhosis, you will have the fibrous tissue accumulation, there will be nodules, and there will be finally disruption of the architecture of the liver parenchyma. Okay. Then causes of the cirrhosis, just now as I was discussing, one is alcoholic liver disease, which will cause micronodular cirrhosis. Viral hepatitis, that is BCD, will cause macronodular cirrhosis. Then the other etiologies are autoimmune hepatitis, nanoalcoholic steatohepatitis, which is commonly observed in obesity, Wilson's, and as well as hemochromatosis. So in case of Wilson's, there is excessive copper accumulation within the liver, that is due to ceruloplasmin deficiency, right? And hemochromatosis, it is mainly due to HFE gene mutation that will contribute to excessive iron accumulation within the liver. And the other etiologies are alpha-1 antitrypsin deficiency, but please remember alpha-1 antitrypsin deficiency is also associated with respiratory pathology as well. What is that respiratory problem? That respiratory problem will be in the form of the pan-acinar emphysema, right? And next is the cardiac cirrhosis will cause the cirrhosis of liver, and finally the cryptogenic cirrhosis. So these are all the various causes of the cirrhosis of liver. What are the complications? If you take the complications, so once the individual goes into a stage of complications, we consider it as decompensated cirrhosis of liver. These complications include portal hypertension, right? And that portal hypertension is due to the liver is completely replaced by the fibrous tissue in cirrhosis. So the flow of blood from the portal vein into the hepatic vein is not possible. So the pressure within the portal vein increases. So portal hypertension is one of the complications. And because of the portal hypertension, the hydrostatic pressure within the portal vein increases and the fluid exudes out into the peritoneal cavity. And not only that, once there is damage to the liver, the albumin level reduces. So there is hypoalbuminemia. And that is also the one which will contribute to decreased oncotic pressure within the vessel. So the fluid will move out into the peritoneal cavity. So that will result in the ascites. And liver is a site where you have detoxification of substances like ammonia. But liver is damaged, so ammonia is not detoxified. So level of the ammonia is increased and ammonia will cross the blood-brain barrier. And that will accumulate within the brain, resulting in the hepatic encephalopathy. Coagulopathy is another important complication, and what could be the reason for this? That is mainly due to damage to the liver. So liver will not be able to synthesize the coagulation factors, right? And next is the spontaneous bacterial peritonitis. So the fluid, the ascitic fluid will become infectious. And the most common organism that will be responsible for spontaneous bacterial peritonitis will be E. coli, Escherichia coli. So SBP is another important complication. Then hepatorenal and hepatopulmonary syndrome, which I'll be discussing subsequently in detail. Whereas, in a phase of compensated cirrhosis, what will be the features? That includes spider nevi. What could be the reason for the spider nevi? That is because of increase in the estrogen level in patients with cirrhosis of liver. So due to hyperestrogenemia, you will have the spider nevi that is mainly observed over the shoulder and as well as the upper thorax, right? And the next important is the palmar erythema, right, where you have the redness within the palm, right? And why is that due to? That is due to visual organ vasoconstriction and cutaneous vasodilatation. That will be responsible for palmar erythema. Dupuytren's contracture, that is due to accumulation of the fibrous tissue within the palmar aponeurosis. There can be clubbing. But what could be the reason for the clubbing? The reason for the clubbing is the primary biliary cirrhosis. That is the reason for clubbing. Next important is the parotid enlargement, where you have the fibrous tissue accumulation even within the parotid gland, resulting in parotid enlargement. Gynecomastia. What could be the reason for the gynecomastia? That is again because of increase in the estrogen levels. So that will result in gynecomastia. Next is muscle wasting. What could be the reason for muscle wasting? So the liver is the site where the protein metabolism has to occur, but liver is damaged, so protein metabolism does not occur, and that makes the individual to have the muscle wasting. Ascites due to increase in hydrostatic pressure and due to decrease in oncotic pressure because of the hypoalbuminemia. Varices because of portal hypertension, and even caput medusa due to portal hypertension. So these are all the manifestations that can be observed. And whereas in men, there will also be testicular atrophy. So gynecomastia and testicular atrophy, both of these are observed in men with cirrhosis of liver, right? Then how will you assess the severity of the cirrhosis? Like we have the scores for alcoholic hepatitis. Similarly, we have the scores for we also have the scores for cirrhosis of liver. That includes MELD score, child pug score, then assessing the value of SAG, that is serum albumin minus the ascitic fluid albumin, that is called SAG. Okay. So MELD, what are the parameters in MELD? That is bilirubin, INR and creatinine. And what are the parameters in child pug? That is bilirubin, INR, albumin, ascites, and as well as the asterixis, right? Then next is the SAG, that is the difference between serum and as well as the ascitic albumin. So that is what is nothing but SAG. So these are the scores: MELD, child pug, and as well as SAG. And the diagnostic test, what exactly is the investigation of choice? Definitely it is the liver biopsy. Liver biopsy is the one which will show you the presence of bridging fibrous septa, parenchymatous nodules, and there will be disruption of the liver architecture, right? Next is transient elastography. It is a non-invasive investigation to demonstrate the fibrous tissue within the liver. And the other tests are the fibro test, ultrasound abdomen, then Doppler, and as well as the serum electrophoresis. Okay, so these are the investigations that we do for the cirrhosis and to make out the etiology for the cirrhosis of liver. Management of ascites. See, the management of ascites is like you need to give a salt restricted diet, right, where you need to permit only 2 to 4 grams of salt, okay, or maximum up to 6 grams of sodium chloride, right, not more than that. And the drugs that you need to give is diuretics, that is furosemide and as well as spironolactone. And abdominal paracentesis has to be done if there is like massive ascites causing respiratory distress, and if there is recurrent ascites in spite of the abdominal paracentesis, then the procedure that has to be done is TIPS, that is transjugular intrahepatic photosystemic shunt, right? Then coming to the management of the varices. So how will you manage the varices? So please remember, if the individual is having non-bleeding esophageal varices, the drug that we give is the propranolol or nadolol has to be given, right? Propranolol or nadolol has to be given, right? But if at all, if the individual has a bleeding esophageal varices, first you stabilize the patient with IV fluids and as well as blood transfusion, and followed by that you can plan for the esophageal variceal ligation, right? And subsequently the drugs like octreotide, then sclerotherapy, and even terlipressin. Actually, if the question is asked like what is the drug of choice for bleeding esophageal varices, terlipressin will be the drug of choice, right? Then followed by that it is octreotide. And how will you manage the encephalopathy? So encephalopathy is due to what? That is due to increase in ammonia levels crossing the blood-brain barrier and ammonia accumulating within the brain. So in order to detoxify the ammonia, the drug that we give is lactulose. So this particular lactulose, it will convert ammonia to ammonium, right? It will convert ammonia to ammonium, and that is expelled out, okay? And next is rifaximin and as well as the neomycin. So this neomycin or like rifaximin is mainly to kill the gut flora, because gut flora also will contribute to the development or production of the ammonia. So once you neutralize the gut flora, the production of the ammonia can be minimized, and for that reason we give rifaximin and as well as neomycin. And next is spontaneous bacterial peritonitis. What is the organism? That is Escherichia coli. And what is the drug of choice? That is cefotaxime has to be given. But in order to prevent the recurrence of spontaneous bacterial peritonitis, then norfloxacin can be given. Next important is, when is that you need to plan for orthoptic liver transplantation? So if MELD score is like more than 17, that is the indication for the orthoptic liver transplantation. That's an indication for orthoptic liver transplantation, okay? And if suppose the donor is the adult, right? Donor is the adult and recipient is also adult, right lobe of the liver has to be taken from the donor. But if the donor is like the adult but the recipient is child, then left lobe of the liver has to be taken from the donor. Why? Because in case of adult, the right hypochondriac space is large. It can accommodate the right lobe which is large. But whereas in children, the right hypochondriac space is small. It cannot accommodate the right lobe of the liver of the donor. It can accommodate only the left lobe of the liver of the donor, right? So this is about the basic introduction to the cirrhosis of liver, right? So now let me just quickly recap the complications of cirrhosis of liver. So the first important complication is the portal hypertension. So how much is the normal portal venous pressure? So the normal portal venous pressure, it is around 5 to 10. So basically what happens in case of the portal hypertension? So there is increased resistance in the portal vein, and that is due to the liver fibrosis, right? And what will be the features of the portal hypertension? See, portal vein, it is formed by the union of the splenic vein and as well as the superior mesenteric vein. So once the portal venous pressure increases, so the pressure within the splenic vein also increases, and that will be splenomegaly, right? And there will be hypersplenism. And the other important features of the portal hypertension will be the ascites. And once the portal venous pressure increases, so there is portosystemic anastomosis. The portal vein also has the anastomosis with the lower esophageal veins, and that will result in the esophageal varices. And there will also be caput medusae. And why is this caput medusae? That is because the portal vein has the anastomosis with the umbilical veins. So portal venous pressure is reflected onto the umbilical veins, resulting in the caput medusae. And the portal vein pressure, it will be more than 12 millimeters of mercury. That is when there will be development of the variceal bleeding, or there will be development of esophageal varices. So the point is, in order to develop esophageal varices, the portal venous pressure should be more than 12 millimeters of mercury. And the other important abnormality secondary to the cirrhosis of liver is ascites. Ascites is that where there is excessive accumulation of the fluid within the peritoneal cavity. And how is this particular ascites diagnosed? This ascites, it is diagnosed by the shifting dullness, fluid thrill, and as well as the ultrasound abdomen, right? So these are the three ways by which you can examine for the presence of the ascites. And how will you manage these ascites? Fluid restriction, salt restriction, diuretics, abdominal paracentesis, and if there is recurrent ascites, then you need to do a transjugular portosystemic shunt is what you need to do if there is recurrent ascites. Next important complication is hepatic encephalopathy, and that is due to increase in the levels of the ammonia. Okay, so ammonia is a toxic substance which will cross the blood-brain barrier and it will accumulate within the brain, resulting in the development of the hepatic encephalopathy. Okay, so when the ammonia levels have increased beyond a normal level, which usually occur in patients with cirrhosis of liver, that is when there will be development of hepatic encephalopathy. And what is the earliest manifestation or earliest clinical manifestation in case of the hepatic encephalopathy is reversal of the sleep rhythm. So during the daytime there will be excessive sleep, and during the night there will be reduced sleep in these individuals, right? And what is the earliest sign? The earliest sign will be constructional apraxia, right? The earliest sign will be constructional apraxia. This will be the earliest sign. And the other features of the hepatic encephalopathy include confusion. There will be flapping tremors, which is called astraxis, and in the later stages the individual will go into a state of coma. And how will you manage? So basically the ammonia levels are elevated, and the ammonia levels have to be expelled out from the body, or the ammonia has to be expelled out from the body, for which the drug of choice will be lactulose. So this lactulose will make the conversion of ammonia to ammonium, right? And it is ammonium which is excreted out from our body. And the other drugs are rifaximin and as well as neomycin, which will clear the gut flora, which are also the sources for the ammonia. Next is the coagulopathy. So the PTI and INR will be elevated, and that is due to impaired synthesis of the coagulation factors. So in patients with cirrhosis of liver, so the clotting factor production, it gets impaired. So thereby the INR will be raised, and even there will also be increased risk of the bleeding. So how will you manage this particular coagulopathy of the cirrhosis of liver? You need to give the fresh frozen plasma, which contains the coagulation factors, and the other one is vitamin K, which is required for synthesis of vitamin K dependent coagulation factors, that is factor number 2, 7, 9, 10. And another important complication is SBP, that is spontaneous bacterial peritonitis, where there is infection of the ascitic fluid, and the most common organism that will be causing spontaneous bacterial peritonitis will be Escherichia coli. Now, what will be the symptoms? So, the symptoms in these patients with the spontaneous bacterial peritonitis, because it's an infection, these patients will develop fever, and there will also be development of the abdominal pain, and there will also be worsening ascites. Right, there will also be worsening ascites. Then how will you diagnose this spontaneous bacterial peritonitis? You need to do abdominal paracentesis. Once you do an abdominal paracentesis, the ascitic fluid will contain more than 250 polymorphonuclear leukocytes per cubic millimeter. Right, the polymorphonuclear leukocytes will be more than 250 in the ascitic fluid. And what exactly is the drug of choice in patients with spontaneous bacterial peritonitis? The drug of choice will be intravenous cefotaxime. That is the one which will kill that E. coli. And what is the drug that we give for prophylaxis? The drug that we give for prophylaxis will be norfloxacin. Right, the drug that we give for prophylaxis will be norfloxacin. So that is about the treatment of spontaneous bacterial peritonitis. Coming to the variceal bleeding, so it is the rupture of the esophageal varices that will make the individual to present in the form of the hematemesis, and because of the excessive hematemesis, the individual can go into a state of shock because of decrease in the intravascular volume, right? And how will you manage this particular variceal bleeding is, first line treatment is you need to connect two large bore cannulas for the two arms. Then you need to start the IV fluid, and followed by that you need to do a blood grouping and as well as cross matching, and followed by that once the individual is stabilized, you need to plan for the endoscopic variceal ligation. And the drug that we give is intravenous terlipressin or intravenous octreotide is what you need to give, right? So intravenous terlipressin or intravenous octreotide has to be given. And when will you give beta blocker is considered as the drug that is either propranolol or nadolol has to be given in the scenario of non-bleeding esophageal varices, right? In the scenario of non-bleeding esophageal varices. And another important complications are hepatorenal and as well as the hepatopulmonary syndrome. So I'll be discussing these two again in details subsequently. But remember, in hepatorenal syndrome, in patients with cirrhosis, these patients will develop what is called a pre-renal type of acute kidney injury. So there will be renal artery vasoconstriction in patients with cirrhosis of liver. Thereby what will happen to renal perfusion? So there will be decreased renal perfusion. That is what will happen in case of the hepatorenal syndrome. And how will you manage this hepatorenal syndrome? You need to give albumin, octreotide and as well as midodrine. Coming to hepatopulmonary syndrome. So hepatopulmonary syndrome is that where there will be pulmonary vascular dilatations and that will be causing the hypoxia. So usually the patient's presentation will be in the form of the orthodeoxia, right? Or we call it as the platypnea. So this is exactly opposite to that of the orthopnea. So orthodeoxia or platypnea is that where the individual will have difficulty in breathing in a sitting posture or standing posture. But whenever the individual lies down in supine posture, the breathing difficulty will disappear. That is what is called orthodeoxia or platypnea, which is observed in patients with hepatopulmonary syndrome. And how do you treat these patients with hepatopulmonary syndrome? The breathing difficulty is mainly because of the hypoxia, for which the patient has to be given oxygen supplementation, and ultimately these patients will be requiring liver transplantation. Okay, so this will be the treatment for the hepatopulmonary syndrome, right? And the next important will be osteoporosis. Now, what could be the reason for the osteoporosis in alcoholic cirrhosis mainly? That is due to malnutrition, right? That is due to malnutrition. So, alcohol use, vitamin D deficiency is the one which will contribute to the development of the osteoporosis. Now, why there is like vitamin D deficiency? Because liver is the site which is required for synthesis of 25-hydroxycholecalciferol, and this 25-hydroxycholecalciferol is the one which has to go to the kidney to form 125-dihydroxycholecalciferol. Now, once liver is damaged, the synthesis of 25-hydroxycholecalciferol is not formed, and that will result in vitamin D deficiency. And how do you treat this osteoporosis? The treatment of this osteoporosis, you need to give calcium, you need to give vitamin D supplementation, and you need to give the bisphosphonates. So calcium, vitamin D, and as well as the bisphosphonates. So these are the drugs that we need to give for the osteoporosis secondary to the cirrhosis of liver. Now, malnutrition. So malnutrition, it is caused by reduced protein synthesis and reduced nutrient absorption. And how will you manage this malnutrition? You need to give high protein diet and as well as the nutritional supplements. And next important complication is SIRS, that is systemic inflammatory response syndrome. This systemic inflammatory response syndrome can occur secondary to spontaneous bacterial peritonitis if the individual is progressing to a state of sepsis. Okay, so if at all there is development of sepsis and not being adequately managed, the individual will develop what is called SIRS, that is SIRS, that is systemic inflammatory response syndrome, where the individual will have fever, tachycardia, leukocytosis or leukopenia. So that is what is the complication, that is SIRS. Next important is hepatic hydrothorax. So what is this hepatic hydrothorax? It is the ascitic fluid which is there in the peritoneal cavity. Through the perforations within the diaphragm, the fluid can enter into the pleural space, resulting in the pleural effusion, right? So there will be ascitic fluid in the pleural cavity. So it is basically a pleural effusion. And what type of pleural effusion is this? This will be transudative pleural effusion. And how is it managed? It is managed with salt restriction, diuretics, thoracosynthesis, and as well as transjugular intrahepatic portosystemic shunt, right? Now, if this particular ascites goes into a state of tense ascites, that is the point when the individual will develop what is called abdominal compartment syndrome, where there will be gangrene of the visceral organs if you don't do immediate abdominal paracentesis. Okay, so there will be increased intra-abdominal pressure from the massive ascites, right, where the patients will develop respiratory distress, reduced urine output, and this is managed with paracentesis, albumin infusion, and then transjugular intrahepatic portosystemic shunt has to be done in order to reduce the pressure within the intra-abdominal cavity, right? So this is about the abdominal compartment syndrome, which can occur secondary to massive ascites, right? And this massive ascites will push the diaphragm up, and that will result in the development of respiratory distress, right? Then coming to the hepatic encephalopathy. In detail, I have said about hepatic encephalopathy, where there will be increase in ammonia levels due to impaired detoxification that will cross the blood-brain barrier. Presentation will be mainly in the form of confusion and astraxis. Drug of choice is lactulose. This is what we have discussed. But let me discuss a little more about the hepatic encephalopathy. Okay. So it is the disease definitely caused by increase in the levels of the ammonia, right? And why is this increase in the levels of the ammonia? That is because of the chronic liver disease. Okay. And because of the chronic liver disease, the ammonia is not being detoxified. Now this ammonia will cross the blood-brain barrier. Okay. So the ammonia is a primary toxin. Now, apart from ammonia, what are the other toxins which will contribute to the development of the hepatic encephalopathy? That includes gamma-aminobutyric acid, mercaptans, short-chain fatty acids, phenols, and as well as the amino acids. Right. Now, ammonia, once it crosses the blood-brain barrier, now within the brain, the ammonia is converted into glutamine in astrocytes. Ammonia is converted to glutamine in astrocytes. Right. Now the glutamine within the astrocytes are the one which will cause swelling of the astrocytes, and this is called as the Alzheimer's type 2 astrocytes, right? This is called as the Alzheimer's type 2 astrocytes. And what are the precipitating factors? One important precipitating factor is renal failure. Ammonia will not be excreted out. Next is gastrointestinal bleeding. So the blood within the gastrointestinal tract will be acting as a source for nutrition for the gut flora. So there will be increased metabolism within the gut flora, producing excess amount of ammonia. That is also a precipitating factor. Infection is a precipitating factor. Constipation, where the bowel does not go out, will also be a source for the ammonia. Diuretics, CNS depressants, electrolyte disturbances like the hypokalemia, hyponatremia, and metabolic alkalosis. These are the precipitating factors for the development of, or for in order to increase the features of the hepatic encephalopathy. And hepatic encephalopathy, you have a grading, and the grading is given by the West Haven classification, in which grade 0 has a minimal change. Grade 4 is that where the individual will go into a state of coma. But in grade 0 itself, you don't have the asterixis. When will you have asterixis is in grade 2, right? And what is the earliest feature that we have discussed in hepatic encephalopathy? That is reversal of the sleep rhythm, that you will observe in grade 1. In grade 1, you will have the sleep disturbances. And grade 3, it is the somnolence, right? Now, what do you understand by this term called minimal hepatic encephalopathy? In minimal hepatic encephalopathy, the patient will have cognitive dysfunction, right? The patient will have cognitive dysfunction that will affect the attention of the individual. And even the psychomotor speed is also being affected. And this minimal hepatic encephalopathy, it is detected via psychometric tests, right? And what are those psychometric tests which will detect this cognitive dysfunction? That includes number connection test and as well as the digit symbol test. So these are the psychometric tests which will detect the cognitive impairment in case of minimal hepatic encephalopathy. And diagnostic criteria will be: number 1, there should be a chronic liver disease or portosystemic shunt. Number 2, there will be altered mentation, that is confusion or coma will be there. Number 3, there will be neurological signs, that is in the form of asterixis, hyperreflexia, and rigidity. And EEG will show you that there is symmetric high voltage triphasic slow waves, right? Symmetric high voltage triphasic slow waves, right? And what is the voltage and what is the frequency? That is around 2 to 5 per second. That is around 2 to 5 per second, right? So the characteristic EEG finding is triphasic wave pattern is what you will observe in case of the hepatic encephalopathy, right? And that too it will be like symmetrical, whereas atypical or asymmetrical pattern can be observed in uremia, can be observed in hypothyroidism, hypercalcemia, hyponatremia, hypoglycemia and lithium intoxication. So whereas in hepatic encephalopathy it is symmetrical triphasic wave pattern, whereas atypical or asymmetrical triphasic wave pattern is observed in uremia, hypothyroidism, lithium intoxication, hyponatremia, hyperglycemia, hypercalcemia and hypoglycemia. So treatment already I have said you, it is the lactulose. What it does, it will convert ammonia to ammonium. Basically it will cause the acidification of the ammonia where in the colon. So that will promote ammonia elimination via the soft stools. Okay, so these patients have to be given a catheresis, or these patients have to be given laxatives to ensure that that particular fecal material is excreted out almost 2 to 3 times per day, wherein the ammonia is also excreted along with that. So rifaximin, it is mainly to reduce the intestinal ammonia production. Zinc supplementation, that will support the ammonia metabolism. L-ornithine L-acetic acid, this will reduce the serum ammonia by the urea cycle. But via urea cycle, this LOLA will reduce the ammonia levels. The additive measures is this will correct the electrolyte imbalances, right? So you need to correct the electrolyte imbalances. What are the electrolyte imbalances? Like hypercalcemia, hyponatremia. So all these electrolytes, so whatever the precipitating factors like metabolic alkalosis has to be corrected, right? Hypokalemia has to be corrected. Hyponatremia has to be corrected because they're all the precipitating factors. And you need to treat the precipitating factors like infection and gastrointestinal bleeding. And you need to use poorly absorbed antibiotics like neomycin or metronidazole as the adjuncts. So these are the additional measures that you need to give in patients with the hepatic encephalopathy, right? Then followed by that, the hepatorenal syndrome or the hepatopulmonary syndrome. So hepatorenal syndrome, actually you have two types, type 1 and as well as type 2 hepatorenal syndrome, right? And this hepatorenal syndrome, first I'll discuss, it is a complication of decompensated cirrhosis. It is a complication of decompensated cirrhosis and it is observed in almost 10% of the cases. And these patients, once they develop hepatorenal syndrome, let me tell you, they are said to be having a very poor prognosis. And these patients will require the liver transplantation, right? These patients will require the liver transplantation. And the characteristic feature of the hepatorenal syndrome is that there will be anuria or there will be oliguria, right? Oliguria or anuria will be there, and that is due to imbalance in vasoconstriction and as well as the vasodilatation. So, but please remember, in hepatorenal syndrome, the only abnormality that will happen is renal artery vasoconstriction, right? But if you take the glomerulus will be absolutely normal. Okay, so normal glomerulus will be there on the microscopy, right? Normal glomerulus will be there on microscopy. Okay, and the pathophysiology in hepatorenal syndrome is there will be loss of vasodilatory prostaglandins. What are those vasodilatory prostaglandins? That is PGE2 and PGI2. And because there is loss of vasodilatory prostaglandins, these patients will have renal vasoconstriction, right? And what will happen to the splanchnic vessels? There will be splanchnic vasodilatation. And because of this splanchnic vasodilatation, this will shunt away, right? This will shunt away the blood from the other visceral organs to the liver. Okay, so splanchnic vasodilatation shunts blood away from the kidney, and that will result in the prerenal type of acute kidney injury. And how will you make out that it is a prerenal type of acute kidney injury? If you measure the fractional excretion of sodium, that is FeNA, it will be less than 1%, right? Whereas intrinsic type of acute, actually this is prerenal. The hepatorenal syndrome will cause prerenal, whereas in intrinsic renal, the FeNA will be more than 1%. Okay, so that is what you observe in case of hepatorenal syndrome. And what is the diagnostic criteria for hepatorenal syndrome? Number 1, there will be refractory ascites even despite optimal management. Serum creatinine will be more than 1.5 milligrams percentage, right? Or rise more than 0.3 milligrams percentage in 6 hours. The urine output, it should be less than 0.5 ml per kg per hour over 6 hours, right? And the individual should not be in a state of shock. The individual should not be taking any nephrotoxic drugs, right? Or the individual will not have any parenchymal kidney disease. Okay, so this is the diagnostic criteria in case of the hepatorenal syndrome, and there are two types. Okay, so out of which type 1 hepatorenal syndrome has a poor prognosis, where there will be rapid progression of the acute kidney injury. So within 1 to 2 weeks, there will be rapid progression. Whereas type 2 hepatorenal syndrome, they are considered to be having better prognosis, and they have slow progression. So the progression will take almost 3 to 6 months in case of type 2 hepatorenal syndrome, right? And the treatment for hepatorenal syndrome is that, see, there is splanchnic vasodilatation, and that is shunting away the blood from the kidney. So you need to give the octreotide or the midodrine, right? And splanchnic vasoconstriction reduces the portal hypertension. But what is the definitive treatment apart from the medical management at one point of time? Because it's a complication of decompensated liver cirrhosis, so these patients will be requiring orthoptic liver transplantation. So that is the ideal treatment in case of hepatorenal syndrome. Next is hepatopulmonary syndrome. So in hepatopulmonary syndrome, you have a triad of manifestation. And what is a triad? Number one, there will be intrapulmonary shunting, that is due to pulmonary capillary vasodilatation. Then platypnea or orthodeoxia will be there, and cirrhosis will be there. So these three are the important features in hepatopulmonary syndrome. So intrapulmonary shunting, platypnea or orthodeoxia, and as well as cirrhosis. Okay, and in these individuals, nitric oxide synthesis leads to pulmonary vessel vasodilatation. Okay, so there is excessive nitric oxide, and that is what is responsible for pulmonary capillary vasodilatation. Next, there will be hypoxia. Why there is hypoxia? Once there is pulmonary capillary vasodilatation, the RBCs which are away from the alveoli or the lung parenchyma, they don't get oxygenated. So hypoxia due to unoxygenated RBC bypassing the alveolar membranes. So the triad will be intrapulmonary shunting, platypnea or orthodeoxia, and then cirrhosis of liver. And the key features of the hepatopulmonary syndrome will be orthodeoxia, that is decreased oxygen saturation. So in the sense, the oxygen saturation should fall by more than 5%, right? So when the individual from like supine position to sitting position, the oxygen saturation should fall by more than 5%, and partial pressure of oxygen should fall by more than 4 millimeters of mercury in sitting posture. So in sitting posture, the partial pressure of oxygen will be less than 80 millimeters of mercury, and there is elevated alveolo-arteriolar gradient. Why? Because alveoli will have an oxygen, but the RBC which is there within the pulmonary capillary far away from the alveoli will not be able to take up that particular oxygen. So the AA gradient will increase, right? AA gradient will increase. So these patients will have intrapulmonary vascular dilatation. Then how will you look for the presence of the dilated pulmonary capillaries? You need to do an investigation called bubble contrast echocardiography that will detect the intrapulmonary shunting with saline bubbles passing into the left atrium. And another important scan is technetium-99m scan. So that is lung scan. So technetium-99m particle that will confirm the abnormal vascular dilatation. And how will you treat this hepatopulmonary syndrome? See, basically there is hypoxia in these patients. You need to give oxygen. That will help in managing the hypoxia. And next important is the orthoptic liver transplantation. So this orthoptic liver transplantation is the one which has to be done because it is the complication which is occurred in decompensated cirrhosis. So that is the reason why you need to do a liver transplantation. Okay, so these are the complications in cirrhosis of liver: ascites, portal hypertension, then bleeding esophageal varices. There can be development of the hemorrhoids. There can be spontaneous bacterial peritonitis, then hepatic encephalopathy, hepatorenal syndrome, hepatopulmonary syndrome. So these are all the complications which are associated with the cirrhosis of liver.